That was excellent. We have plenty of time for opening up for question and answer.
Great job, everyone. Enjoyed it. This is for Chad. The graph, the pie diagram that you put up for ERISA plans, I think one of the things that I'm not sure that you conveyed because of time was what that actually can do for a business in terms of lowering their indirect costs. So you put down on there the reinsurance, and I'm a partner in a large urology practice, and we are self-insured. But we also created a model in Atlanta, Hip Nation, where we're going to employers and showing them how when you pull out certain services from their claims history, that the reinsurance, which they're paying, they're not actually setting that money aside necessarily. They're actually paying reinsurance rates. You can go to the reinsurers. So just for everybody who's not familiar with this, so if you have a business or you approach a business and you know that the people in your business are going to cost you a certain amount of money per year. They cost, let's say, your claims history in our practice is $1.8 million. So we know that that's what it is, and we can lower the cost by doing things like direct primary care, but we also pay for reinsurance so that when we hit 1.8, our reinsurance kicks in. So you can go to the reinsurer and show them what your costs are, and they'll look at the claims history and they'll go, oh my gosh, you're not going to even come close to this. We're going to lower your reinsurance 20%. And so this becomes incredibly attractive to the businesses on the indirect costs, the reinsurance that they're going to be paying.
Yeah, absolutely. If you noticed, my speech got really pressured towards the end. This thing blinks red. It's really annoying when you've gone over your time. And I went over my time, and I could see Lee nervously twitching. So you were right.
That's my baseline. So, I mean, you guys painted an incredible picture of what can be direct primary care. Is this easy? I mean, is this an easy thing to do?
No. No, it is not, Lee. It's not easy at all.
Care to elaborate?
I guess it's compared to what, you know? I mean, the current system is horrendous. So, I mean, yes, it's very hard. I think about how hard I work. I'm blessed. I have about 700 patients. I'm probably going to cap at that level. And I work pretty hard, and it was hard in setting up. It takes some courage and bravery. Julie did a wonderful job of describing why. It's you know, morally, ethically, our own lives are literally at stake here to do it. But it actually changes the kind of meaning of what you do, because before you're doing things that you know are meaningless, and that seems like a waste of your life, and that takes a toll on your soul. But now you're doing what we all knew being a doctor is going to be hard, but you thought it was going to be taking care of people, and so, okay, that's a sacrifice worth making. It's not worth sacrificing your life for a meaningless bureaucry.
But don't you feel...
It was hard before.
I was going to... My analogy would be, well, I've said this before, nothing pays like autonomy. And one thing we have to be mindful about in the DPC movement is there's a number of incredibly enthusiastic mentors who are very, very successful, who truthfully aren't taking a substantial income. So I think that's a testament to our profession, actually, that there's people who would gladly do this, not for free, but would gladly do this at reduced income to their prior system job because they love it so much. I literally changed light bulbs in my system job, and that was sort of the end of it. But my analogy would be that if you woke up every day and walked out of your house and got punched in the face and you knew it was coming, or you woke up every day and walked out your door and knew you had to run a 10K, but no one was going to punch you in the face, I'd take the 10K, and I hate running. So, I mean, that may be silly, but my system job was like getting punched in the face all day long, and there were no options around it, and I just had to take it.
Okay. I see a question there. I'm going to get to it in just a second. I just want to... So the ethical issues when a patient is paying you directly now, you know, the argument is, you know, aren't you then incentivized to do something maybe you wouldn't normally do? And do you have sort of new boundary challenges you have to deal with when you're in this? Time boundaries, relationship boundaries. Does that affect you at all?
I think a lot of people perceive that you know, as Josh said, there's a difference between being, you know, very patient-centered and you know, being a pushover. So I think that, yeah, sometimes patients, you know, perception of who we are is different than what my perception is, and the only way you can kind of overcome that is to develop a good relationship.
I mean, because Michael Jackson had a direct primary care physician.
Yeah, I'm not.
Yeah,
He was a
that's a good
cardiologist,
point.
actually.
No,
so.
I mean, that's a great point, and this model is right for people with borderline personality disorder, and it really is. What's nice is you tear down so many boundaries. You know, people think you're insane to give your patient your cell phone number. That's not the problem. But I would say you have to be mindful that you don't do anything you wouldn't have done in your prior job. It's not changing the cost construct doesn't change the standards of care for a family physician. It doesn't change the nature of our opiate crisis. It doesn't change your relationship to your patient from the standpoint of who you are to them. It changes how you can interact with them. So, you know, hey, I want to meet you for coffee, and can I get my Norco without paying the membership? No, you know, no and no.
So you have to learn how to say no.
Yeah, well, and I think if you have 30 minutes to say no, it's a lot easier than if you have 5 minutes to say no.
You have to learn how to fire people, and you have to be comfortable with firing people, and you have to recognize who is going to suck your bone marrow dry, and they would have done it in the system. Well, there's two things about DPC that are different. In the system, you're not aware of who's fired you. They just don't show up. But no one comes and says, you know, Jane Smith isn't paying her bill anymore, or Jane Smith doesn't want to be a member. So you have to learn how to not take that personally. And you have to learn very, very quickly that your relationship with your patient is you pay me, and I'm your doctor, and I save you money. And that's the contract. And if they don't pay you, they're not your patient.
Yeah, I one time heard I was talking to a doctor about what I do, and you know, one of the questions that I'm sure you guys have asked is, well, what about patients who can't afford it? So I was talking to a doctor kind of in the system, and he asked me that, and I said, well, you know, that's kind of also true of, you know, before we get into how much I charge and who can afford what, and I said, well, what about your patients who can afford you? And he, with a straight face, you know, and he really believed this, said, well, all of my patients can afford me. Like, I mean, he literally thought, and I was like, well, of course, you know, because they wouldn't get in the room otherwise. But really, you know, far removed from that. So, you know, I think sometimes I've made the analogy that Blue Cross or Coventry or Medicare, you know, the EOBs that they pay me aren't somehow altruistic. They don't come with like some type of like, you know, ethical stamp on them. So.
One thing that's interesting is I see more Medicaid patients now outside of the insurance model than I did when I was in it. I mean, I have so many patients who have Medicaid, no one takes it. They say, listen, I'm happy to pay you, I at least can see you. And these are people who are economically disadvantaged. And so it really shows that our prices, the affordability is kind of a fallacy. These are people who come in with massive tattoos, and those cost a lot of money and things of that sort. So it's just where they put their priority.
We have a question over there.
My tattoos are none of your business.
Yes.
And your tramp stamp is none of our business?
DPC. Very good. My name's Rod Story. I'm from Moscow, Idaho. My question is, has DPC risen to the point where it's being noticed, and is it getting pushed back? If there is pushback, how are you addressing that?
Yeah, I mean, are we being noticed? Yeah, I mean, I think so. I think, you know, legislators and other larger family med and primary care organizations definitely know who we are. I think there's still a lot of misconceptions. Pushback, depends how you look at that. But yeah, I mean, I think there's still a lot of skeptics. I don't think there's any like direct attacks yet, but I think that will come, and that's why we're all here.
If I could address my experience with that, here in Florida, we've tried to get direct primary care legislative protection now for 7 years in a row. The last 4 years, we actually got a bill. This past legislative session, we actually got the bill through 7 committees. The fact that we had to have 7 committee hearings on this bill is crazy, but to give you an idea of how much pushback, we cleared all 7 committees unanimously, not a single no vote, not a single utterance of any opposition publicly, yet we don't have the protective law in the state. And when you pull up the list of who lobbied on the bill, because in the state of Florida, you have to register when you lobby privately on a bill, and there were 200 lobbyists registered on the bill. Almost every one of them were from the insurance companies and large hospital corporations. Yeah, well, not one of them uttered a word publicly.
If you think about it, I actually met with, we have a state senator in Michigan who's a wonderful advocate. His name is Patrick Kolbeck, who helps us out. I met with him and a head of an insurance company recently in the state of Michigan to try to find more compatible plans with DPC, but they're an HMO. And when their medical director was there and they were listening intently, and I give him credit for that, they were listening, and finally he gets his furrowed brow and he goes, well, wait a second, we are a health maintenance organization, we manage healthcare. under your model, what will we do? What will we manage? And he's like, I'm like, oh man, shoot, he figured it out.
We have a question here at this microphone. She's been waiting, and the gentleman up here.
Dr. Cheryl Trudy. I've been in DPC now for about a year and a half in Jacksonville, Florida. So I know we're probably going to go into nuts and bolts as the conference goes on, but maybe just an overview of the two frustrations that I've experienced opening it is one, the negotiation for some of these services has not been easy in my area of the country. It's really been difficult. And I think that that's just my region, not necessarily the state of Florida as a whole. And the second thing, like you said, is plan compatibility we've struggled with. Again, in my region, we have some difficulty with, I used to come from Chicago where there was a whole breadth of plans. Here in this particular area there is. So I don't know if any of you have faced that. I know maybe not specifically, but if you could just speak in general about some of that, I'd appreciate it.
Yeah, I think that's the hard thing about hard things. They don't necessarily want to give you lower prices, but they also, at the level of who you'll talk to often, they aren't given authority or permission to give you lower prices. Lower prices has never been the focus for them. Let's inflate it to here and give you a made-up discount to here, and we'll send you an EOB that changes that later, yada, yada. So they're just not used to transparency in pricing, in cash, and things like that. So they're usually just not equipped well to deal with that. I think that's one of the values of the DPC model is talk with the community. Most doctors are more than willing to give you their rep or tell you their prices, or they're posted on their website and say, look, in full transparency, if Dr. A is getting these prices, then I want these prices. And if Lee can get an MRI for $100 less than I can, then I'm going to keep, calling back and asking for better.
You can come to Florida.
It's expensive to get here. So you do just have to push, and I think it's just uncomfortable for us. We're not used to that. Vance is right over there. He can probably tell you a lot about that, and we need to get good at it. It's a skill that we just need to be comfortable being uncomfortable, asking for better prices, saying I want to renegotiate this, pushing it down, and they're always going to give us feedback and pushback. But our why, everything we do is for the why of our patients. There's few things more important than saying I'm going to save these 600 people as much money as I can on whatever mix of services.
I want to get to this last question here because we're running out of time. But the one point I wanted to make to what you're saying is even if you can't get a discount, start with just a price. I mean, you can always work the discounts after you build the relationship, but just start with a price. And also, I think the biggest issues I've heard nationwide are areas that have large HMO penetration. The folks up in New England, and Jeff Golds is probably going to talk about this when he talks.
But can I make one comment? Because this gets to what I hear, which is I don't have a business degree. I'm really stressed out about the business component. I don't know how to negotiate, or comments like that. And I know that's not exactly what you're saying, but to some of the newbies out there, I took Josh Umbehr's imaging pricing the first time I went in and negotiated imaging with our local imaging company, and it fundamentally changed the negotiation because I said, this guy in Wichita is getting this, we're not even close. And I would just encourage all of you to remember that you spent at least 7 years negotiating, right? We had a new job every 4 to 6 weeks that we had to show up, interview for, prove we were worthy, known as our rotations. And that first time you held a scalpel and got to do skin-to-skin on a C-section or a central line, you were negotiating. Every diabetic patient you see that you plead to please write down their sugars, that's a negotiation, saying no to Norco request. So we are good negotiators. We just don't see it that way.
Thank you. Last question.
Hi, Dr. Hall. I'm the Cape Coral area. Just maybe later in the day, because I don't have a schedule, are you going to talk about opting out of CMS and things like that?
Yeah, Phil Eskew is going to talk all about that in his panels.
Okay. All right. Thank you.
All right, we're going to go ahead and take a break. Let me just look here at the schedule. So, yes, I want to thank these panelists again. Everyone's going to be around all day today and tomorrow, so make sure you grab some folks.